David, Adams, and Anyanwu are going to present a series of 3 cases, all very interesting. For each case, we'll have a different panel. If we may ask the first expert panel to come on up, Joe Chikwe, Michael Halkos, Marc, Michel, Pellerin. This always feels a bit like an oral board.
You're the examiner.
Hi guys, how you doing?
Hey, good to see you again.
So this is a
Exactly.
we're gonna get going because we have several cases to show everyone, and we're gonna split it up into 3. We'll split it up into 3 different topics, and the first one we'll talk about is going to be about just the simple stuff. So these are, again, were my disclosures. These are Ani's. And the first one we'll talk about is just some simple concepts about decision-making in patients over 65 years of age. If we have time, we'll get through 2 of them in each one of these sessions. So first patient is an asymptomatic 65-year-old gentleman. He's been under active surveillance for moderate MR for 8 years, and now it's progressed. Here's his echo. Let the panel let me know what you think. Michael, very simple. What do you think?
Years.
Yeah, he's been
Looks
followed. He
worse.
just gets sent to us because now he's got this echo. So
Yeah, it
any
looks-
thoughts on transthoracic?
I mean, to me, it looks a lot worse than just simple moderate MR that's been stable. Atrium's not, it's slightly dilated. And I can't tell, but it almost looks like there's some posterior leaflet restriction in some views.
Yeah, you sort of get the sense, and again, this is also to remind everybody, the transthoracic, most of the time will give you all the answers that you need. Occasionally, you need more imaging, but he certainly has important mitral valve regurgitation. I think the long axis sort of gives you a sense there's posterior leaflet prolapse. Looks like anybody else? Joanna?
I thought the jet was anteriorly directed.
Yeah. Looks like if you look at that non-color view on the long axis, you really get the sense you can see in some of the beats as they move the probe around a little simple rupture of the posterior leaflet. Now it's focal, small, different than the valves we were looking at earlier today. Here's the transesophageal. That should add a little more clarity. Marc, what do you think?
Eccentric, anteriorly directed jet. Eccentric jets are often underestimated, but I think he's ready for the operating room after the rest of his pre-op testing.
Yeah. So again, pretty focal prolapse, very simple jet. This is one where you see it better in esophageal than transthoracic. So here's the summary for just writing down things from the echo report now. Flail P2, severe MR, small ventricle, low risk. So here's the first question is active surveillance still reasonable?
Can you tell us how bad his symptoms were again?
No
right now?
symptoms.
Asymptomatic
Feels fine.
on no medications.
That's why that's a good question.
Asymptomatic on no medications. I think I'd ask the patient. I mean, his PA pressures are normal, no symptoms, no medications.
Small ventricle, small atrium, simple prolapse. Michel, what do you think?
Well, it's, I would say it's 80–90% of our practice these days, and I'm discussing with the patients the natural history of MR, and I think there were plenty of papers from our friends from Mayo Clinics under the leadership of Maurice Enrique Serrano, and he says that by 5 years you have 20% risk of AF or congestive heart failure, and by 10 years there's 40%. And I discussed this with the patient and say, well, we know what we're doing. So based on the severity of MR, I would present possibility for repair, which would be quite simple here.
Yeah, I agree. When you present these cases to a room full of cardiologists, still a majority of them will be quite content with active surveillance. And that's despite a phenomenal New England Journal of Medicine paper that 20 years ago showed that the mortality of asymptomatic P2 prolapse like that with an ERO of 40 is about 40% at 5 years, which is remarkable. It's not benign.
And if you operate on patients that are not very symptomatic, you bring them up to their normal life expectancy, which is not the case when you operate on class 3 and 4 patients. So we discussed, it's not an emergency, but I think if the patient understands his disease, he goes in or out of treatment.
Yeah. Well, it's interesting. This question is just interesting to hear how everybody handles it, because I do think that, well, one thing's for sure. Let me ask you another question. Let's just pretend he doesn't want surgery. What's your management plan going to be now? He says, look, I feel great. I don't know. I'm going to get around to it, but right now I'm going to go play golf this summer, which is what we all say in New York because it's a short season. What do you say?
3-month echoes.
Anybody else?
That might be a little bit too frequent. I'd probably say have him come back in 6 months.
Let me confuse.
But also, how did we get severe MR out of that anyway? Oh, we look at it and we say, oh, there's a lot of color there. That's got to be severe. I didn't see any measurements that defined it as severe.
But Mark, how do you know the patient is asymptomatic, though?
Well,
You're trusting that the patient is asymptomatic.
you could put him on an exercise and see if he gets pulmonary hypertension or it worsens.
David, let me confuse the pen a bit more. This patient had an MRI as well as part of the preoperative workup, and the ejection, the regurgitant jet was only 8%. Now what?
Dismiss. Not interested. Sat on the jack out of Torrelboard for 8 years. We're not drinking the Kool-Aid.
Now, that was my point, too. Whoever called that severe MR is smoking very funny cigarettes. And
They're legal here.
you could do, oh, it is here. Okay, we're in Canada. But it's not severe MR, and we're kidding ourselves. So a good cardiac MR to give you the regurgitant fraction and all the flows would be in order here.
Well, guys, I hate to humbly disagree with my very senior colleagues here that both have the gold pinned on their lapel at the ATS, but we're not going to start telling the echo labs that eccentric jets with flail segment are not severe MR. We'll need a few more echocardiographers here to defend the other side. I mean, this is, in every definition I understand, is severe MR. And I certainly don't think that our echo lab is overestimating mitral valve regurgitation. So it is severe MR. I mean, let's agree that's a flail segment with an eccentric jet with a Coanda effect is severe MR. We can talk about the degree. Remember, in tricuspid now we've moved to severe massive torrential. We're used to operating on the patients that have massive and torrential MR. But we do have to start somewhere, and I hope we're not going to start telling patients that have eccentric jets with flail segment that you don't have to worry about, you don't have severe MR. We can talk about you don't have to rush into surgery, that's active surveillance, but we can't start redefining what MR is just because we're surgeons. What were you going to say, Michel?
I was agreeing with what you were saying. If the patient comes in the office and he understands the disease, it's not, we don't need to do an emergency operation, but if he disagree with the approach, he can be seen in 3-6 months, and then we find out.
Yeah, what we tell patients is the guidelines. Guidelines say, the little box says, if you're not sure you can repair the valve, go back to follow-up every 6 months, 2A indication. So I do think, and what I always remind the patient is we're not doing echoes to look for good things. We're only, like Joanna said, about 3 months, we're only looking for bad things. And many patients that were presented in this morning's sessions, by the way, were all under active surveillance, and I noticed many of them showed up with ejection fractions of 50% or 55%. So I think the guidelines do have it right. Flail segment probably needs to go to the OR. Joe?
I'm curious, though, because collectively I think we've identified that challenging scenario where we have 20% of patients with inconsistent results. You've got a transthoracic echo where the jet did look wider and more severe. It's obviously a little bit downgraded on the TE. That wasn't quite so compelling. You might have gotten an MRI. They may come back and tell you it's mild to moderate. You stress them, you've got something more. So I'm curious how the panel navigate this, particularly in asymptomatic patients when that's the sole indication almost for surgery.
We would have stressed, if this patient really wanted to wait, we would stress them, honestly, just to confirm their ventricular response is okay and look at their pulmonary pressures and then restudy them in 6 months.
Can I make a comment on being asymptomatic, sort of what Ani was asking? You know, a lot of these patients, when you question them, they sound like they're asymptomatic, and they can tell you that they have tremendous exercise tolerance. You know, we operate on a lot of these patients, and while this is not a criteria that you could ever integrate, I've found that when you talk to them post-op, they always tell you that they can exercise even more. And we have a lot of very active patients, and they can quantify, you know, how far they were biking before, and you said, wow, they were biking 100 miles a week, so they don't need an operation. And they come back and they tell you a month or two later they're biking, you know, 150 miles a week with less effort. There's this sort of, they're always going to be functionally better without whatever degree of MR that's representing.
Yeah, I really like to look at their age and how many minutes they went. I know we're going to look at right ventricular recovery and estimated pulmonary pressures and regurgitation, but I like to know how much you did. If you're under 50 and you can't go 7 minutes on a treadmill, I'd probably stop on page 1 and tell you we're learning something. Here's the second question for this patient, and that is, are we going to put him in a TIR randomized control trial? Let's just pretend he's symptomatic. He's short of breath, he's got that prolapse. Is he a candidate for a TIR randomized control trial?
How old was he?
68, 66, I can't remember. He's over 65. Marc?
Well, I think it's interesting because you have to look at it the approach of we don't think TIR is good, so we don't want to do it in this patient. But the idea behind the randomized controlled trial is to prove one or the other, or equality or non-equality. So if we don't participate in randomized controlled trials that have been approved or have been considered to be appropriate, maybe we're doing patients 10 years from now a disservice. Now, I'm not sure that's a case in TIR, but it certainly was a case for TAVR.
Gilanoff, what do you think?
I discuss it with him. And more often than not, this kind of patient comes and says, I want surgery because I know that the long-term results are great and the operative mortality is incredibly low. But yes, I would offer it to him because if we don't engage in these trials, the field is going to pass us by. And the hypothesis of our trial that Joe designed, the hypothesis is surgery is superior. And I believe that we will validate that hypothesis.
So, David, I agree, Marc, and I believe in randomized trials, but there has to be a question of equipoise in this situation. So you have to ask yourself when you're having this discussion with the patient, do I really believe that there's equipoise with the two treatment options in a 65-year-old asymptomatic patient with P2 prolapse with not a severely dilated annulus? So they put a couple clips in, you come out with a gradient of 6 or 7, no MR. But can I honestly have that conversation with the patient that 10+ year results may be as good with TIR? And in this specific case, I don't think I can.
I think if your interventions are leaving patients like that with a gradient of 6 or 7 and moderate MR, then clearly you should not be having that conversation with the patient. That said, there are groups that can get no MR and a minimal gradient. And the challenge is, right now, 70% of patients that get TIR are having it for degenerative disease, P2 prolapse, right? A quarter of those patients have got an STS-PROM less than 2%. They are not high-risk patients. About a third of patients that come to the office want to have a conversation about TIR, and I do not have great data to say, I'm pretty sure surgical repair is better, please believe me. So, unfortunately, we do need a randomized trial, so I am going to have that conversation with the patient, but I'm going to tell them my strong view that although I think they may get a good short-term result, we really don't know what the long-term outcomes are. And oftentimes, I would say the majority of times, those patients will always elect to have surgery.
I think Joe, I'm not sure I agree with that, that we don't know, because you're suggesting that we don't really know what is better. I don't know whether any of you were at the AATS session where Saibul Kar gave a great talk, and he talked about equipoise in clinical trials. And as an investigator, we have to be clear in our minds that we don't know which is better. So we honestly feel we don't know. If there was a parachute and you're jumping out of a plane, you wouldn't necessarily say, well, we don't know because we don't have the data. So we do have enough data to tell our patients which we think is right. And the question, Joe, is, do you really think for a 65-year-old that you don't know which of the two is better?
I'll say
your
this,
honest-
Andy, as you said to me about
yeah.
15 minutes ago, for every single technique that we showed this morning, be it complete rings or flexible rings, near chords, cortex transfer, you had one person saying this is gospel, and 5 minutes later you'd have somebody else saying this is voodoo.
Yeah.
We don't always know.
No, but in this instance, a 65-year-old symptomatic P2 prolapse, for example, are you saying you don't know whether surgery or catheter is better, so you have that indifference to say you're going to put them into a clinical experiment? That's the question.
I think you could probably say that in an 85-year-old and an 80-year-old. Maybe it is better if you can get a good result.
We do know one thing, and that is that in the paper that Raj and you published, Joe, the degenerative subgroup of low-risk patients had a survival penalty at 1 year. 25% had moderate or greater stenosis or moderate or greater MR. So a survival penalty at 1 year. And that was the real world, which is where we're heading after any super controlled, well-selected randomized trial gets controlled. So I think we do know. We may be trying to generate some more data, but we do know. And I do know that none of you on this panel would ever get a clip for that pathology.
No, you're right. I would.
I'm right.
I want one of you guys or one of you women to operate on me, but for the good of the greatest number of patients, and I'm not saying we sacrifice this patient so we get an answer for the rest, but for the good of the greatest number of patients, we've got to complete this trial, get it in a super high impact journal like New England Journal or JAMA, and let the rest of the world know, these 70% of people who are getting clips for that, let them know, if we prove it, that that is not what you should get.
But using that argument, you've thrown a bunch of people to the wolves just to publish a paper. Because
No.
you're already saying that surgery is better, but do you have equipoise?
I have a lack of firm data. So
Yeah,
I didn't answer your question.
I think the real question is not about, TIR is actually quite useful. You couldn't be a mitral center and not have that in your practice because you can save a lot of people. I think that the charge to asymptomatic healthy 65-year-olds with that disease, which is why I decided to show that, was a little bit aggressive. Let me show you one other quick thing just for the echo. 66-year-old, you notice the pattern, active surveillance, and they always come back with things. Here's her echo. So what do you guys think of that one? Any comments, thoughts? Just got kind of fun for a different reason. So mid-systolic regurgitation, not clear prolapse, moderate MR, red is moderate MR. Moderate MR, mild to moderate TR, EF 50%, tachybrady syndrome, STS 0.8. You want to watch her or you want to operate on her?
Yeah, this patient is clearly symptomatic, and so I think if we don't do anything, deterioration soon is going to occur. So I'd say
Any
yes.
disagreements? Moderate.
But she's symptomatic, I think.
Symptomatic moderate MR, yeah.
Is she having any ventricular arrhythmias that we know of?
No, she's having tachybrady. It looks like mostly AFib driven. Is she a candidate for any of this stuff?
What was her age again?
66.
66. Like, is her anatomy suitable for it?
I don't think so.
Huh?
I don't think so. She had bileaflet prolapse. I would need to look at the echo again. That she
Yeah, it's
had any
amazing. I
mass.
had to look so hard to find a case I thought we could at least discuss over 65 that had anatomy that would be perfect for a tear. I really did. I mean, like, I was driving the guy, it's crazy. I'm like, guys, we got to have a case that's like perfect for tear, like a perfect anatomy case that will go in. But the reality is almost all of them don't until it gets approved, then everybody will be a candidate. Pat?
Just another thought on this patient. We started seeing these kind of patients that were going in Degenerative, and they were being referred for a maze, and they didn't have much MR. Check the genetics on them. A 66-year-old, relatively young people, arrhythmias, ejection fraction down to 50%. We had a hit rate of like 75% of them had an underlying genetic cardiomyopathy, and they actually needed a heart failure cardiologist, not a surgeon.
I'm glad you mentioned that because her EF actually at one point was 45, but it'd come back up to 50. You're probably right. So we'll just get to the bottom line about the tachybrady since we have Dr. Cox here and Dr. McCarthy. What do you think? You know, it was interesting, yeah, in the operating room, she went from, when we were opening up just before we got on her lung machine, she'd gone from heart rates of 20 to heart rates of 130, sort of just as we were watching. I mean, it was quite impressive. Well, at any rate, what we did do for her was we did repair her valve, and we did do we obviously asked EP about all that. She had a pulmonary vein isolation and a valve repair. It's actually so far done very well, and I will say that her post-operative ejection fraction, that's why I didn't know whether this rhythm had something to do with it, but her post-op ejection fraction came back to about 58. So at any rate, those were the two cases we wanted to discuss. We'll keep moving so we continue on time. Thank you very much for coming up. Yeah, Jimmy. Say what, Jimmy? It did.
The magic of beat.
Clip and a pulmonary vein isolation is what she had done. All right, guys, thank you very much. We'll keep moving now.